It is with great honor and pride that I'd like to welcome all of you to the 3rd International Women in Surgery Career Symposium. My name is Sharona Ross, and along with my colleague and co-chair, Dr. Julie Freshlage, welcome. In just a moment, we will present a short video montage of television clips from a recent American film and TV shows, which takes you along a continuum of how a woman's role has been and is still often perceived within the popular culture of today.
Okay, guys, I got one. Would you rather get a massage from a man or surgery from a female doctor? Wow.
Like minor surgery?
No, serious surgery, like a blown kidney or something.
Jeez. Good question, Peter.
Is the man gay?
Nope.
Is the female doctor at least Jewish or Asian?
No, but actually, you know what? I'm going to take it up a notch. Hispanic female doctor or gay male masseuse?
Hispanic from Spain?
No.
Oh. So it's basically, would you rather get a massage from a gay man or die?
It's just, this symposium is about information and about empowerment, but it is also about you. It is about the information you take away from this next few days and also the empowerment you pass on to others.
We still have challenges as women surgeons, but those challenges delve right into opportunity. And I think that's what we're going to talk about today, to focus on what we can do to make things better. We still have challenges ahead. Now, the opportunities, I would tell you, are never better. Look at the role models that you're going to see. Look at this conference. Would this conference have happened 5 years ago? Would it have happened 10 or 20 years ago? I don't think so. And I certainly don't think we'd have this many people in the room. So already you can see the momentum.
So why does this even come up as a title of a talk? And I can hear some of you squirming in your seats when I say there isn't a glass ceiling. So we do talk a lot about the pipeline, you know, sooner or later, that fact that there are more women in medical school than anywhere else, that the internship classes seem to have so many women in them, the pipeline, the pipeline, the pipeline. I've been hearing about the pipeline for 20 years. So I did mention everybody's, the year that they finished their training, so that we could sort of start to think about the pipeline and how long it does take to actually get to leadership roles. But it does seem like we're not really, the pipeline hasn't really fulfilled itself at a high level.
So during this time in 2004 in the same program, a resident became the first woman resident to get pregnant, and the program director, sad to say, also a man, said, "You will have to take the year off to have a baby." And that's inconceivable, and it's kind of laughable in this day and age. It was laughable to me. I wasn't the program director at the time. It was laughable to me because my wife's a gynecologist, and she took about 6 minutes off and worked up until like 5 minutes before she delivered. Our last 2 children were both born on Saturdays, and she worked on the Friday before she delivered the babies. So, you know, there aren't any men that can do that.
So what is the engine of the economy of the 21st century? Is it technology? Is it science? Or is it perhaps innovation, and especially education? And if we focus on that, it is essential to prepare our students and to teach them for technologies that have not been invented yet. And keeping this thought in mind, students and our educators face a new challenge.
So why do we care about selection? Well, of course, not everyone can be a surgeon. We're very privileged. It takes both ability and desire. You want to identify which students are going to be happy in your program, who's going to do well. And in some programs, it's important to identify students who will move our specialty forward. And that's really what our program is about, looking for leadership, the next leaders, the new generation of surgeons.
So I decided to talk about a decade of experience. This is my 10th year. I've never given this talk. It's a little bit to show you what you do as a chair. I wish there was a book that tells you exactly what to do when you show up, and I sort of did it on the fly, trying to figure out what was best, because I came into a very good program, a very good hospital. You saw it last night, an amazing place. And what was my job? And my job was to change the culture of surgery at Hopkins and throughout the world. That was what my plan was, and I didn't quite say that to everybody. But I had a dean that actually wanted that to happen. So the key when you take these big jobs is you need to be in sync with those above you. You have to learn to manage up, and then you also have to manage down, because as I came in, there was a lot of trepidation, because John Cameron's amazing. He'd been there for years, his whole career, medical school and residency and faculty and chair. And so what did I have to offer, except maybe to mess it up? So you want to make sure you keep all the strengths and the power and what you had before and go forward. People ask me all the time, how did you get here, and how are you still standing, and what is the most important characteristic? And I think resilience is the one. Resilience is when things go wrong and you can still keep going. Resilience is when you're disappointed. Resilience is when you don't match one program or you get the other, or you don't get the job you wanted but you get the other. I was turned down to be chair at University of Michigan, University of Colorado, University of North Carolina, but look what I got. Okay, so when you get those things turned down, it's very disappointing. You're like, well, what's wrong with them? Of course, which is always a good thought. They are wrong. You were right. But being resilient is so key to all of this, because frankly, what really matters is what's inside of you: truth, integrity, your family, your friends, and also realizing that when a door closes, another door will open. You don't have to beat it down. That's what surgeons usually do. You can go through another door.
Better communication equals better teamwork. And you've heard teamwork go through the many of the conversations and presentations this morning, and I really view that as the critical element of bridging the communication gap, and that is tightening the teamwork that takes place between the surgeon, the anesthesiologist, the nurse, the tech, and any other member of the team that's required to be there for our complex surgeries that we do today.
Despite this increase in women medical students, this past year, only a small percentage of surgery applicants were women as compared to men. It's been studied, and there's many factors that influence a woman's decision to choose surgery, such as the perception of lifestyle and family life, the relationship during the third-year clerkships, the anticipated workload during training, as well as individual factors.
Of those 204 patient respondents, 57% were women. 28% of these patients have had a woman surgeon, and 96% of these patients were satisfied with their care. We further examined patients that were greater than the age of 40 years, and interestingly enough, we find that patients greater than the age of 40 have given women surgeons a significantly greater score than men surgeons in areas of empathy, compassion, and approachability.
So, is humanism in surgery an oxymoron? Well, I think you have to remember the definition when you're trying to connect with your patients. Remember interests, values, and dignity. And all of these are very, very important, but dignity, I think, most of all.
Just one comment. It's really a pleasure to hear that today at a university like Johns Hopkins, you don't have to hide the fact that you have kids. When I was applying for medical school, I had 2 kids at home, and I was just, I was 5 months after, so I had to lose the weight. I made sure that everything looks tight, so nobody would ask me whether I have kids at home. When I applied for residency, I had already 3 kids, and I was like, oh my God, I mean, if they knew that I had a 9-month-old and then 2 others, they won't spend the money on me. So I made myself, I lost the weight and everything just so I won't look that I had a pregnancy or look pregnant or however you want to see it. But I was really afraid that that question will come up. Today when I interview residents, what I see is, like Julie says, it is absolutely a strength. If you're able to manage your schoolwork, which is getting good grades because you're here for an interview, and you're able to manage home, the kids, and then the husband, and then your career here, I mean, that's the kind of person we're looking for. And so I'm absolutely honored and proud to hear that we have at a university that is so prestigious, to hear that we are welcoming women and actually seeing them in a completely different light. I mean, this is progress. Thank you.
I've been asked to talk about the importance of having a mentor, and I think I can relate because I've had a lot of them through my lifetime. As Heather said, I am a surgeon scientist, and doing that in trying to bridge the gap between being a surgeon and going into research, you really kind of need to get help on both sides. And in fact, I'm a surgeon because the fact that one day I was sitting on a conference at Duke Medical School in Grand Rounds and I heard a surgeon talk and it connected with me, and I went to his lab and said, I'm going to do research with you. And then he convinced me to sort of follow in his footsteps, and then I became a surgeon. So really the whole reason I'm here this day is because of a mentorship.
It has to be that you want to do this because of the it factor. You want to do it. And ultimately that's got to have something to do with this really complex milieu of curiosity, who you want to be and the way you're wired. And because maybe you want some recognition, that's basically the it factor. So when do you start this? You start now. You look at all the people here today. Look at all the data that's out here in the audience today that could be collected and then analyzed and reported about various aspects of women in surgery. Everything you do, you can be scholarly about, and then you will find that you're a scholar.
Voice. So think, how do you want to be judged? What do you want people to think about you? The people you're interacting with, the patients, the doctors, the nurses, the fellow surgeon, your peers, what do you want them to think? Now, I want to level set here. I know it's challenging. You have long hours, you have hectic schedules, you're in scrubs, you're not in scrubs. I know I'm not pretending this is easy. It is not. But everything goes back to intent and goes back to goals. And so if you have in your mind that I want to be as polished and as professional as I can be in this given moment or in this given day, then it will show. You will dress accordingly and you will act accordingly.
After the symposium, we approached Dr. Ross because we were interested in conducting a survey of our own in order to explore the reasons why the wage gap exists and why there are so few minority women surgeons.
Interestingly, 96% of minority surgeons believe that racial bias and discrimination exists in the workplace, while Caucasians are actually split 50-50 on whether racial discrimination still exists. So next we asked how each surgeon perceives his or her income compared to other surgeons with similar credentials. 80% of men responded that their income is comparable to women with similar credentials, while the majority of women respond that they earn less than men surgeons.
Which the Wall Street Journal last year said women physicians, not just surgeons, women physicians earn $17,000 less than male physicians. Now this was using the 2010 census, and so it's 2009 data, and it said this is not because of the hours that you work, similar to this, and it's not because of the specialties that you choose, and it's not because women tend to go into lower paying some primary care specialties as well. None of that. You couldn't explain it away. So if you can't explain it away, you have to say this is a very serious discrepancy. It has something to do, which we'll get into, is how and why it happens, but nonetheless, it's bad. And it's not only bad, but it's been getting worse. So if you think that you're coming into medicine now, or for those of us who are older, that you've been in medicine long enough that it's changing, that's not true.
There was a time when, certainly when I started my training, and Julie and others, where it really was, we had major pipeline issues. My medical school class had about 15% women. With the program where I was at the University of Virginia, I had never had a woman resident at that time. There were certainly no women on the faculty. It really did look like a deep, dark tundra. And it wasn't just but a few years before that this was the way medical student handbooks looked. It was the boys in white. And obviously now when we look at our equity positions posture for women in terms of access, really in college, we're going to have to start worrying about our men going to college if you look at the demographics going forward. In medical school we know we're 50-50. I'd love to see it stay 50-50. I think there's great merit in that diversity, and yet if we look to Europe and other countries, we're heading to 70-80% women in medical school.
I grew up in an era when a young girl would have never seen a female physician or even a woman executive, when most women would have relinquished their careers or designs on careers in order to become a full-time housewife and mother. In medicine, when I was in medical school, I had actually never seen a female surgeon, and it wasn't until I was a third-year medical student that I laid my eyes on the first female surgeon, I actually wanted to go up and touch her to see that she existed.
We need to learn from our own career. Every time somebody says to me, oh, but you've done this and that, you've traveled there, I kind of always used to think, I was just lucky. It's just luck that I did this, presented there, got this award, but it's not luck. If you look at yourself, if you look at your career, it's not coincidence. We are self-directed. We know what we want. We just have to learn from ourselves as well.
I think it's great to encourage women to be surgeons. And actually, in looking at that, I think that one of the things that we forget is that we need to start early. How many little boys tell you they want to be a doctor or an astronaut or whatever, and you ask a little girl, and they may not have ambitions of that sort because we've never really inspired them to do so. But I think so. I think we should do that. We should be more actively involved in school programs, and I'm delighted that now so many women do have children, go to the schools, and do participate in their children's school activities so that these kids see that women can be doctors, can be surgeons, because it leaves a lasting impression. I also think that we need to be more involved in the first and second year of medical school. Even now, I still teach in our bioethics course for the first and second year students, and it's a great opportunity to meet them and to have an influence on them, because many of them come to medical school believing that surgeons just go to the operating room, cut people up, and don't care about them, and on and on. And so if you go and you talk to them about the ethical issues, about caring for patients, about your values as a doctor, it's very important. And more of them will start to consider the fact that they may like to be surgeons.
And then you have to make sure that the home environment is also supportive of work stresses. Now sometimes, I think most of the time actually the chairs don't know about this because people don't want to tell us that. But I think that it's important to have a support system around the faculty so that they can address these issues.
Is that among married women, 44% were married to other physicians, and 27% of those were other surgeons. And in contrast, the spouses of male surgeons, only 29% were married to another physician, and 5.3% were another surgeon. So you can see it's totally reversed. I mean, that's not surprising if you think about it. When you're a woman and you're in the hospital all the time and you're spending all your time there, that's who you meet, is other physicians. It's unfortunately, it's just a reality. Men have a lot more options in the hospital, you know, other healthcare professionals that might not be as interested in marrying a female surgeon.
So the background to the internet dating is in 1877, Alexander Graham Bell invented the telephone. It was originally intended for business, but it turned out to be very incorporated into social purposes. And as sociologists have looked back on the telephone, the interesting thing is it reinforced your own pre-existing social network. So you called friends you already knew. You didn't make new friends through the telephone.
And I guess as a role model in addressing what I've been asked to talk about in today's talk is showing my children that I fit in and they fit in with my life, and we fit in all together. And there are various ways that I can go about that. Obviously being successful in my career is important, but clearly showing that I enjoy it. I'm encouraging others, I'm encouraging them, but also they feel involved. I mean, I can't tell you how many ward rounds the kids have been dragged on, or how many clinics that they've sat in because I've had to dash to nursery to pick them up, and I've still got 2 patients waiting to be seen. But actually they seem to enjoy it because they get biscuits and treats and things.
Same thing at home. If you marry someone or partner with someone who expects you to bake brownies and be standing at the door in a pinafore at 3 p.m., then they're going to have a rude awakening when they marry a surgeon. But you have to be able to articulate that. You have to be able to say, I mean, I dated my husband long distance for part of the time, but as a first and second year medical student, and then we got married. And he knew when he married me what he was signing up for. And he knew that because I told him, like, dude, don't cook, don't really clean, and I'm gonna be super busy, but it's gonna be awesome. And so if you say that and they run screaming for the hills, then they probably weren't meant to be partnered with you. If you don't say it, and you give the impression that you're going to be something other than what you really will be or what you really are, then you're setting yourself, your spouse, your loved one, your kids up for disappointment.
As we all know, with the advent of new technology over the last 30 years, surgery has been on the forefront of a paradigm shift from traditional open surgery to minimally invasive techniques. With IRB approval, an online survey was created and sent out via email to men and women chief residents, as well as attending surgeons that were in attendance at the Southeastern Surgical Congress and last year's Women in Surgery Career Symposium.
Based on the available data, our hypothesis that women surgeons are more likely to embrace and practice minimally invasive surgery because of its elegance, reduced physical demands, practice patterns, and lifestyle is not supported. However, we did notice an interesting trend in our survey. The new attendings in the 1 to 5 years out of training tended to have responses that were incongruent with our findings.
Because history is part of surgery, and change is part of history and surgery. And today, big scar, big surgeon statement doesn't exist anymore. If we have no scar or a hidden scar is even better for the patient. And if that corresponds also to less wound infection, less likelihood of having an inguinal hernia, and probably also faster recovery for the patient and better results in terms of physiological stress, then we're really looking at modern surgery and modern medicine.
So in the context of this uncertainty, it seems more fitting to offer concluding remarks with a focus on young women considering futures in surgery. We don't know the exact face of healthcare reform, but we do know the rapidly changing face of healthcare and of surgery. So if you look around and look at your neighbors, you are the face of the future of healthcare and the future of surgery.
What we really need from all of you is to go out and lead. We have a pipeline of women surgeons now. There's tons of women surgeons. Now we need you to go lead. We need you to do what Dr. Newman told you, is don't say no to the big important things. Say no to the silly things, but say yes to the big important things. Being a chair, being a chief, being president of the American College of Surgeons, being president of AMWA. It's great changes. You can do amazing things. You get to make rules, you get to change the rules, and you get to bring all of you, which will be a whole other group in 10 or 20 years. The changes that have happened in surgery with women in the last 30 years are nothing but a miracle. It's just absolutely amazing what's happened. But we need you all to lead. So go forth, do good things. That's what I say to my residents as they leave my office, and go lead surgery. And again, thank you all for the planning committee, and to Sharona, and for all of you being here today. Safe travels home.